Welcome everyone to the IHE Standards Acceleration Lab. I'm hoping that you are now seeing my screen. My name is Keith Boone. I'm an informatics adept for Audacious Inquiry, and I'm here to basically take you through a brief explanation of what the SANER project is. And then we have a number of folks with us who are going to show you a demonstration of a lot of the different pieces of it. So thank you for joining us. We're going to go into a demonstration. We're going to hear first from Dan Pollock from CDC talking a little bit about public health agencies defining measures. And then he'll hand it off to SANER, Hans Buitendijk, and they'll introduce the others as we move along. So I'm going to hand it off to Dan, and Dan's going to speak to you briefly about the role of CDC in defining measures at a national level.
Thank you, Keith. Yes, I'm Dan Pollock, and my role at CDC is that I lead the unit at the agency that was responsible for not only with many of the entities that Keith just showed on the slide before, but also with healthcare facilities and health systems throughout the United States. And we launched COVID surveillance in hospitals last March 27th using the data collection form that Keith displayed in an early slide. So we went very rapidly into a data collection mode for COVID, admittedly manual. We put something together in a matter of 2 weeks and implemented. And the way we went about that is to focus on what data would be needed by public health and emergency response agencies. So we focused on the patient impact, the infection burden placed on hospitals of COVID patients, and also hospital capacities in terms of ventilators, beds, and other assets. So each of those are a measure that consists of numerator and denominator, typically a ratio. You can think of them in a sense as a form of vital statistic. We often think of vital statistics as births and deaths, but measurements of healthcare and healthcare capacities are also a form of vital statistics, be they the number of COVID patients among all inpatients at a given point in time, the availability of mechanical ventilators at a given point in time. These are vital statistics for the response. And so NHSN serves as a measure specifier, a measure data collector, and a measure output producer. And we're very grateful to be part of the SANER initiative. We want to transition as quickly as we can from the manual dependency to automation across the board to the fullest extent that we can on all of the vital statistics that comprise our surveillance efforts for COVID. So with that, I will pass it to my colleague Hans Buitendijk at SANER, and Hans can pick it up from there.
Thank you, Dan. Appreciate it. And my name is Hans Buitendijk. I'm with SANER as Director of Interoperability Strategy. And we have been involved with this project from the start and really are looking forward to its progression because at that time, as requests are being made, filling out forms, going to portals, submitting spreadsheets, clearly what was needed, but looking long-term and or as soon as possible to be able to take advantage of more standardized, automated fashions to get the data out is really a desire to get us there, because whether it's for existing ongoing surveillance support, or whether it's an emergency that we need to find out additional information, the faster we can enable the right parties to get access to the right data, the better it is. And FHIR has started to provide an interesting opportunity and capability to enable that, to get better access to the data. We have been involved in earlier connectathons focusing on the submission of SANER-based measure reports. and have been able to take some of the data that we have used for other reporting to convert that, effectively put it out in that format, and it has been very successful submitting that in as part of the Connectathons. This time around, what you will see is that a couple of the different scenarios are going to be trying to look at specific data available, in our case, the EHR, that enable access to that and identify, measure contributing data to that. So another flavor of, rather than pushing data out through a measure report, how can we query for data that is relevant to the investigation. So as we go through, and that's where we'll hand it off to the next group, is that's how we're going to participate in this demo. So it's our Fire Sandbox that we have available, firecerner.com, where we have populated that environment with a number of different patients with a variety of data that would or would not qualify them for the queries that are going to be in play. So with that, I think I'm going to pass it to Lantana, which I believe might be Leora first or somebody else.
All right, here we go. Thank you all. So what we're going to be doing here in this part of the presentation is focusing on an application called NHSN Link. As the title here says, or the subtitle, it's an open source reference implementation for NHSN reporting. So just quickly, Dan, you already had your little speech at the top there. Do you want to add anything at this point?
Not at this point, Rick.
All right, sounds good.
Everyone knows me now.
Yes, they do. So I'm Rick Geimer. I'm the Chief Innovation Officer at Lantana. I'm also one of the co-chairs of the Fire Infrastructure Working Group at HL7. Done a lot of work on many implementation guides and such. So this is very exciting to be able to sort of take a look at what's needed for reporting during this pandemic and what NHSN needs are going forward to do modernization and more automation. So what we've developed here is a tool, as we mentioned, that aggregates, calculates, and shares line level data with NHSN using the measure framework that Keith and Dan had spoken about briefly. And I forget, Dan, did you want to give a quick intro to NHSN goals around NHSN Link beyond what you shared earlier?
I think between what I said earlier and the bullet points on the slide, I think it's well covered.
Okay,
so
good.
You go ahead.
I will plow forward here. So what we've done with this application is so far we've since the Fire Connectathon, the HL7 one in January, and now we've tested NHSN Link against 3 measures. The one we're going to be focusing on today during the demonstration of the discussion is the COVID-19 risk factors, comorbidities, complications, such like that. But really, the framework that we're going to be using can work with any SANER compliant fire measure. So we've also developed around medication administration reporting and COVID administration admissions from a skilled nursing facility to a hospital. But again, we're going to focus on COVID-19 risk factors for this one. So basically, the application, in a nutshell, what it does is, first of all, it will retrieve measure reports from NHSN. So I assume there's a server at NHSN that where this application can go and pull measures from. And that's what it actually does. We don't assume it does work that way. So in this case, NHSN can make updates on demand as needed to things like the COVID risk factors measure, and then we would be able to pull that whenever there's updates made. The next part of the process is actually receiving a list of interested patients. Now, one of the downsides of the current US CDI and frankly the US core implementations out there, that are based on US CDI is that it's very difficult to actually search across patients right now. So in other words, it's not very straightforward to query EHRs and say, get me all patients with COVID-19. Rather, you kind of need to know your patient IDs ahead of time. Hopefully that's something that will be addressed in future releases of US CDI and US Core, but for now, that's the kind of limit. So somehow we need to receive a list of patient identifiers out of BAN that can come from any number of mechanisms. But at the end of the day, it's a list of patient IDs that are of interest for the report. Next, what we do is once we have those IDs, we actually go against the EHR's FHIR interface and scoop up data that is relevant for the reporting. In other words, out of the patient IDs that we were passed, we might gather all the patient's conditions, encounters, medications, labs, etc., for the reporting period. We then gather those and we store those in a FHIR server called CQF Ruler. CQF Ruler is just it's basically a fork of the Happy FHIR server that implements measure evaluation. At some point that will actually be, or actually it is at the moment being merged back into the main branch of the Happy FHIR server, so we won't even need a separate fork at that point. But for now, it is a separate fork. And what happens there is all the FHIR resources that we scoop up from the data sources are stored in CQF Ruler, and then we call evaluate measure against the data that we've stored there. And it'll go and it'll run the measure calculations. It'll first of all scoop up all the, or rather gather all the data that is needed for evaluation. It'll then determine how many patients are in the initial population that it's interested in, and then if there are other population counts defined in the measure, like numerator and denominator and such, it'll also gather those counts together. But the most important thing for the NHSN purpose here is the actual sending of line level or patient level data to NHSN. So along with the counts that are evaluated in the NHSN link application itself, we send the data so that if NHSN, for instance, needs to rerun the measures or tweak them, they don't have to go back and regather the data. They've already got that sent. And how it's sent is as a measure report bundle. So we generate a FHIR measure report resource, which will contain references to the line level data that is used for evaluation. And then before we send it to NHSN, we actually resolve all those references and produce a FHIR bundle resource that contains the measure report and all the that data that I spoke to. So when you launch the application, the first thing it's going to do is ask you to log in. It basically does this via OAuth using the same, all the Smart on FHIR required stuff there. So you can connect using, Microsoft account, GitHub account, Google account, etc. Once you log in, you will see the application page over here on the right, which will have an NHSN link. It'll have you select a reporting date and then a measure. In this case, we're actually listing 4 measures. I believe the slide said 3, but this COVID-min is really just a test measure that we created just to make sure, is it plugged in? Is everything working? When we give the demonstration, we'll be selecting the risk factors measure there. Then when you click generate report, it'll go, as mentioned previously, to scoop up all the data. In this case, we'll be targeting Cerner's FHIR sandbox. So we'll be scooping live data from Cerner. It'll then put it on our server, as I said. It'll calculate the measure results, create that bundle with all the data, and you can then choose to either save it to a file. So if you want to save it locally and review the data, you can do that, or you can hit send a report, in which case it'll post the data as a FHIR bundle to NHSN's server, which is will be demonstrated by the folks at Leidos today. And then they'll take the data and proceed. So I think at this point, Dave, are you ready to do a demonstration? So I will stop my screen share and let you start.
Sure, yes.
All right.
Let's hope it works just like that. That screen, okay.
And we see it.
All right, so like Rick just mentioned, this is the login screen. And we are in. We're gonna select risk factors, which we have defined. The denominator is Again, this is configurable or updatable, but the denominator is inpatient encounters with a positive COVID diagnosis. And the numerator is just the percentage of those patients that have, I think in this case, it is a VTE, venous thromboembolism. But again, it can be any condition. Rick mentioned this is pointed at the SANER sandbox. So we know from testing that there are 2 patients that meet that initial population on September 28th of 2020. And click generate report. Like Rick said before, this is now going and getting those patient IDs. It is first getting the latest measure definition of risk factors and throwing it on that CQF fire server this is sitting on. It's then getting the patient identifiers for this date and scooping all of the patient data, not just their COVID related information from the fire sandbox, putting it on that same fire server and running evaluate measure and producing this. Like we see here, we have the SANER sandbox currently has 2 male patients of that ethnicity. One of the supplemental data we were able to get into the report out is the text chief complaint for these patients. They this one happens to have shortness of breath. You see their race there. The initial population and denominator as 1. There had been 2 there, but again, it's a sandbox, so it's kind of always changing. And the really cool part about this is, again, the fact that all of the patient's data is scooped, not just the COVID stuff. So we can show saving it off to a file real quick. Downloads. Let's take a look at that bundle that is saved. So you see not only the measure reports that we just looked at on the screen, but all of the underlying conditions. So we see here acute kidney injury, rhabdomyolysis. That's the patient resource. So I won't go through all those, but yeah, it is all of their other comorbidities, as well as location information, which Leidos and Esri, I think, are going to show on a map, so we can get some pretty cool visual readouts of it. And the last piece of functionality I want to show is clicking send reports. And I could show you in Postman that just sent successfully, but basically that just posted that whole bundle to the NHSN server. And I think that is where I can stop showing.
Yeah, thanks, Dave. And so Keith, I think it's back to you or whoever was next in line.
All right. So very quickly, what I'm going to show you is what's in our back end, and it being part of a back end, you're not actually going to see a whole lot of activity happening on a console. So I've instrumented the code to just sort of report as it goes through, pulls the measure data. Okay, now you should be seeing my development environment.
Yep. Looks
Yep.
good.
Mhm.
Yep.
All right, so I'm just going to go ahead and launch a test run. This would normally be something that would happen at a scheduled time where our back end would go off. It's grabbed the measure report from the CDC server. It's now going through and reading data from the EHR fire server that it's connected to, and then using that same sample data that was installed in the SANER server, we're now computing the measure. And in here, we've got the measure report itself, reporting that for the particular date range that we selected, there were 10 patients who are part of the initial population. And we can see that 6 of them have cardiovascular disease, 2 of them have chronic kidney disease, 2 of them have diabetes, 4 of them have hypertension. So they're essentially stratified by different disease categories based on a number of different codes that are configured in the measure. And so this is evaluated by reading the fire data from the EHR or the fire server that the system's connected to, and looking for conditions with particular codes, and then counting the matches that it comes up with for those. And then, as Rick had previously mentioned, we're then also collecting up all of the resources that were used to evaluate the measure. And this is an additional feature that we added in response to ballot comments to the SANER implementation guide, the notion of being able to collect supplemental data associated with the measure that can be used to do things like risk stratification. So you're not just getting raw counts, but you have other data that helps you do risk analysis based on the data and produce risk adjusted scores for more advanced analytics. And so that's pretty much it that I have to demonstrate. It's not very fancy. It's not a whole lot of flash, just showing you that it can work. And now we're going to turn it over to the Leidos team, and they can show, start showing you the pretty diagrams that you'll be seeing as a result of what these servers are producing.
Thanks, Keith. Appreciate it. My name is Romain Tinney. I'm a software engineer for Leidos, and I currently work for CDC on the NHSN project. Okay, so we're going to talk about the measure reports and what happens after the measure reports are submitted to CDC, or for the Connectathon purposes to the NHSN fire server that we have running. Right now, we are focusing on the comorbidity rates associated with COVID positive cases. These measure reports are submitted to the development fire server, as I mentioned. We have a process that's called whenever a bundle is received. So a bundle is a collection of measure reports on various fire resources in that bundle. That process picks apart that bundle and iterates over all of the patient data, especially the conditions that are in that particular bundle. For those conditions, we calculate a comorbidity rate, depending on what the conditions are. And the weights are from 0 to 10, just to give you an idea of what we came up with. And the weights were chosen arbitrarily. All the data is notional. It's just fictional data, synthetic data, however you want to term it. The conditions are evaluated, weighted, as I mentioned, and then they're averaged together, generating an overall comorbidity rate for the patient. In addition, those rates are also summarized to the facility level. So just to give you an idea of how the conditions are weighted, for example, pulmonary embolism, we've got rated as 8. Hypertensive disorder is rated as 4, and etc. So what I'm going to demonstrate is basically this particular data mapped in a geographical format map. And I'm going to swap over to that now, and we'll see how live presentations go. Let's see. Okay. So hopefully you're seeing the geographical map and what you're, say again?
We are.
Okay, excellent, thank you. And what you're seeing, the circles or clusters with numbers are the average comorbidity rate for all of the facilities, all of the hospitals in that particular geographic location. And you'll notice as I zoom out, you'll see that the clusters coalesce, and the graph is, or the chart is dynamically recalculating that average. So we went from, maybe in this particular case where there's maybe a few hundred hospitals representing this one circle. As you zoom out, you might be looking at 1,000 hospitals, 500 to 1,000 hospitals that represents that particular circle. You can also zoom in to the facility level. And I have one that I can zoom into and show you on Staten Island, New York, this particular facility. And you'll see that I chose a comorbidity rate of a magical number, 3.14, because I'm going to refresh the screen to show you that we actually did get new information from the payload that Lantana submitted previously. Okay, so while I'm doing that, I'm going to refresh the screen. And I'm going to go over here and show you the payload that Lantana submitted just recently. Unfortunately, the timestamp is in GMT, but you can see this was just a few minutes ago. That was during the presentation that this particular bundle was actually received on our Fire server. And if we go back here, once the data is loaded, we'll zoom back in to Staten Island. Give it a little time to catch up here. And you'll see that the comorbidity rate is now 1.11. So basically just demonstrating that this is a live demonstration. The data that was submitted by Lantana was ingested by our Fire server, and the process that's updating this particular map pulled in that new data as the new data was available.
And just a shout out to Hans as well. Remember, we were pulling the data from SANER first, so it was going live out of there as well.
So I believe that's all I have. Thank you.
Okay. Let me know if you guys can see that screen.
We can.
Okay, great. So this is Mike Scholl. I'm a senior solution engineer on the Esri Health and Human Services team. So really what we want to emphasize here is that now that these measures have been made accessible, and we've seen how you can visualize this information in dynamic maps and tables, we really want to pull this data into other kind of location intelligence environments as a consumer. So that's going to allow us to plan for capacity at a regional or national level. It allows us to visualize trends over time and really make some actionable decisions. So what we're looking at here is that data pulled into a consumer application, in this case, just a configured ArcGIS dashboards. And really within this tool, which is completely protected by credentials, we can select a Fire server and visualize that summary report of all of the information available, like the number of occupied beds, occupied ICU beds, available ventilators. So really getting this precise understanding. And it actually even can include things like dynamic meters and charts that really give us at a glance situational awareness. Something can turn red when it needs attention. So to dive deeper, we can even go into these lists again in the consumer application and view the specific capacity at one facility. And this information can be presented over time, really like we've done with these measures. So I could, similar to before, put in a date range of information that we know that the sample server has. Let's go ahead and put this cap on there. And now all of our charts and information can update to reflect those different time periods. Now there are other ways of visualizing this new information. Again, in these applications, people can toggle on and create heat maps, for immediate visualization of the data. So in this case, we're looking at the number of positive COVID tests from each one of these sample facilities. And really because this data is aggregated from multiple different networks, we can look at, not just this flat hotspot, but even consider things like emerging hotspot analysis over time. What areas are getting better and which areas are getting worse, potentially lining it up with interventions by local communities. You can also create multivariate maps within this platform off of this data set that highlights the number of, for example, test results at each facility as a total number. So that's that total size of the circle here. And then we can even highlight the number of those tests that were positive. And that's that darker shade you're looking at on the map. So that could be a very accurate understanding of the impact of COVID-19 very quickly at a glance here. Again, just looking at some simple visualization. You can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of available beds at each facility. And this facility in red, might be one that's at capacity. So you can even create a color-coded map that looks at the number of avail So again, this is really valuable information at a 30,000-foot view. But what would be great is if we could put this into the context of making a decision. So let's hypothetically say that a nursing facility needs to determine the number of ICU beds, available within a certain distance. This could be for planning purposes, or it could be actionable. We need to send a patient somewhere. Well, using location intelligence, we can click a point on a map and set a buffer distance, and we can quickly get these summary reports that outline the capacity regionally. This could be straight line, which is as the bird flies, or Euclidean distance, or it could be a driving time or walking time buffer, following the road network, and maybe even considering traffic. And so because we know specifically now, even spatially, where there is bed availability, we can actually configure a very simple routing application that's only going to go in here and search for facilities that have capacity available. And because this information is streaming in near real time, you could avoid sending a patient potentially to a facility that simply might not have space. And again, because we're dealing with these consumer grade applications, this is something that could be viewed, very cleanly on, a mobile device potentially. So really giving, access to this information to those who need it, most at their fingertips here. The final thing I do want to show here is, the concept of looking at the environment surrounding these facilities, with other pieces of data. So for any given facility, we can actually generate service areas around them. So it's going to highlight, the communities that are likely to arrive at that facility by walking or by driving. So we can go ahead and generate that here. And then we can actually enrich these areas with environmental data from a variety of sources. So it could be census data. We could look at CDC social vulnerability data or market research information. So in this case, at this facility, looking at some of those measured reports, we see a high instance rate or prevalence, depending on when it was diagnosed, of cardiovascular disease and obesity diagnoses. So we can start to ask questions like, why is that the case? Well, we see here from our market potential data that these communities are spending, a lot of money on fast food, rarely eating organic foods based upon market surveys. They fall in some of the highest indices in the United States. So we can now start to, really get a hold on why these are happening. And, if we're starting to look at, mitigating these factors and improving health outcomes, layering information like accessible pharmacies, healthy food options and parks, and then feeding this data back into a system where providers could leverage it to make the best care recommendations based upon each patient's environmental circumstances. You could even compare this environmental information with the facility information, determine things like, do I have enough PPE to support this population given the current environment, in the case like COVID. So really more than just visualizing and plotting, content on a map, which is great. We've seen how powerful that can be here. The availability of this data to consumer applications is allowing us to plan for capacity, visualize trends over time, and really make actionable decisions where that was previously impossible. And now because this data is part of the ArcGIS environment, it can be connected to other state public health reporting systems like Javari EM Resource or Web EOC, along with a number of other integrations supported by ArcGIS.